So, hello everyone, welcome to this Septodont webinar about preserving pulp with tricalcium silicates, not to say biodentine. My name is Sandro Calais. I work for Septodont as a general manager for Belgium and Netherlands. This webinar is intended to replace a symposium that we wanted to organize in Belgium, but unfortunately, due to the crisis that we are all facing, we had to cancel. 10 years ago, biodentine was introduced in many countries. And in Belgium, Professor Rita Kouwels and Professor Martens were among the first to use biodentine on children. They started also clinical research, a lot of experiments. And today, I think we have the great privilege together have three major speakers that together, I think, have the most extended knowledge about tricalcium silicates. During the lecture, you will be able to write down your questions. So you can see that on the control panel, there is a section called the questions. And at the end of each lecture, so the speaker will reply to your questions. But first, let me introduce Professor Martens. So Luc Martens is a full professor at the Department of Pediatric Dentistry at the University of Ghent. He founded and chaired for more than 30 years the master program of pediatric dentistry. He is a founding member and the past president of the Belgian and the European Academy of Pediatric Dentistry. He authored many papers and promoted PhD works, and is again today highly involved in clinical research. So I'm very pleased, Professor Martens, to have you with us today, and the floor is yours.
Okay, thank you very much. Thank you very much, Mrs. Calais. And to all of you in the cloud, welcome to our webinar here given from the Ghent University. Yes, and here you see now the Belgian flag is moving, so we can also start this presentation. Ghent University is situated in Flanders in Belgium, and Belgium is in the center of Europe. And the university, as you can see here, is situated between the capital city of Brussels and the North Sea coast. We are in Belgium very famous for chocolates, which are all now hidden now in the airports globally, and also for Belgian beers and the mussels from Brussels. But today, we would like to present you, of course, the webinar on preserving pulp with tricalcium silicates. And I'm very happy that my nearest collaborators are with me today, and we will do this, the three of us, Dr. Rajasekharan, Professor Kouwels, and myself. First of all, I would like to emphasize again that this webinar replaces our international symposium, which is indeed cancelled due to the globally COVID-19 crisis, but it was planned on May 29th, and also especially on the occasion of 10 years experience with biodentine at our department. Before starting the complete lecture, I would also to focus on the conflict of interest, which is important. It's of course clear that we have made a lot of workshops for general dentists, and that we have made also a lot of lectures worldwide and in our own country, and this was supported by the Septodont company. And finally, I would like to declare that we obtained also some research funding via real contracts by University of Ghent and the Septodont company. It's important to know this beforehand, that Septodont also had any influence in neither the design nor the data management nor the published manuscripts. Having said all this, it's really time to start. We will have three lectures for you, one on the material aspects by Dr. Rajasekharan, then a more clinical presentation on regeneration and long-term follow-up of TCS in traumatic injuries by Professor Cowles. And then I will finish this whole presentation with a brief overview of our research data and some future perspectives. And now the floor, or better the cloud, is for Dr. Siva Prakash Rajasekharan. He came in our department 10 years ago as a master student of pediatric dentistry, but he stayed with us to do exclusively research on tricalcium silicates, which ended up in a PhD thesis. And today he will lecture for you on the dental material aspects of these products. Please, Siva, you can start your lecture.
Hello, good afternoon. As I was introduced by Professor Martens, I am Dr. Rajashekharan. I came to Belgium in 2010, right about the time that Septodont also came to the Department of Pediatric Dentistry and Special Care in Ghent University. And I'm a postdoctoral researcher now, and I was asked to present now on the tricalcium silicate material aspects. So, as a dentist, every dentist needs the best material to have the best outcome possible. And understanding material properties is the first step towards predicting a better outcome. Around 150 years back, if you look at the history, material properties were not so much of importance when Hunter et al. Said that he showed 98% success with sorghum molasses and sparrow droppings for pulp therapy. And around the same time, the German dentist, Dr. Witte, she showed that the first reported use of Portland cement to fill root canals and to treat vital pulp tissue. Portland cements were invented in the year 1824 by Joseph Aspin. It's a combination of tricalcium silicate, dicalcium silicate, tricalcium aluminate, and aluminoferrite. Mineral trioxide was introduced around 150 years later in 1993 by Dr. Mahmoud. And mineral trioxide, when introduced as ProRoot MTA, was white Portland cement combined with bismuth oxide for providing radiopacity. But from the introduction of mineral trioxide, there was a shift in endodontics from preservation to regeneration. Up until then, most of the materials used for pulp therapy were either inert or had little bioactivity compared to mineral trioxide aggregate. And this shift to regeneration was possible because mineral trioxide aggregate or Portland cement in general had two important qualities. One was that the cement was hydraulic. The hydraulic nature of the cement means that the cement comes as a powder, and to harden, it needs to be in the presence of moisture, or to be put in other ways, it can set in the presence of moisture, which is very advantageous for us as a dentist because we come across different moisture situations in the practice, such as the dentinal fluid, the tissue fluids, or the cavity itself could be wet for some reason due to blood or so. But the advantage of this material is once it reacts with water, it forms a solid, and then it's not anymore influenced by water. So this was one of the important reasons why mineral trioxide aggregate was a big boon. And the second one was its bioactivity. When mineral trioxide aggregate or tricalcium silicates in general, when they're mixed with water, they form a calcium silicate hydrate gel and calcium hydroxide. The calcium hydroxide then dissociates into calcium ions and hydroxyl ions. The hydroxyl ions are responsible for the alkalinity of the cement, or the high pH to say, and that is responsible for the antibacterial activity. On the other hand, the calcium ions, they are responsible for mineralization and also for the bioactivity. How do they do this? The calcium ions bind with any phosphate ions in the surrounding, such as those from the blood or tissue fluids or from the dentine, and they form a layer called apatite. It's a very complex chemical reaction involving 5 different stages, but I'm not going to go into it. But it's just to say that the material has good bioactivity. And of course, in these years, 35 years of using mineral trioxide aggregate, no one can argue that mineral trioxide aggregate has excellent clinical results, but it's not a material without any disadvantages. Mineral trioxide aggregate has a long setting time, difficult handling, does not have adequate strength, coarse particle size, initial instability at the site of application, and most important of all, which is very dissatisfying for both the patient and the dentist, is the discoloration. In an attempt to improve the mineral trioxide aggregates and to eliminate it of its drawbacks, a lot of new commercial cements were launched in the market. And then it becomes very difficult for the dentist to make a logical choice as to which tricalcium silicate should I choose. So let's try to, if we could sort all these different commercial tricalcium silicate cements, we would see that the evolution from MTA happened only with 3 different parameters. One was variation of cement particles, either by elimination of the impurities and minimizing particle size, or by adding an alternative radiopacifier other than bismuth oxide, or by using additives to either the powder or the liquid component to enhance a specific property of the cement. So these 3 parameters were either used alone or in combination, and that is what is now available as all the commercial cements available in the market as an improvement of MTA. If we take tricalcium silicate based cements as such, they have 3 different components to say. One is the cement component, and then the additive component, and the radiopacifier component. We will take a look into each of these components, and you would see, first we'll start with the cement component. And here in this image, you see that the cement powder of 3 different tricalcium silicate based cements, biodentine, Metsem, and MTA. The green is MTA, the blue is Metsem, and red is biodentine, was analyzed by X-ray diffractometric analysis, which is actually a technique to show what are the phases present in the powder component. And we all know what is the composition of these cements: tricalcium silicate, dicalcium silicate, calcium oxide, the radiopacifier, and so on. But what was very surprising was that even though we call all these cements as tricalcium silicate based, 2 cements, MCM powder, the Metsem powder, and MTA powder, contained one type of tricalcium silicate, while biodentine contained another type of tricalcium silicate. So then we had to go and look as to what is the difference between those 2 types of tricalcium silicates. And if you take a look at the powder diffraction file handbook for all these kind of materials, we see that the tricalcium silicate present in MTA powder and Metsem powder is the one that is obtained by purifying Portland cement closest to alite, and the other one present in biodentine is obtained from laboratory synthesis of pure tricalcium silicate. So based on this, we can say that the cement component of tricalcium silicate based cements can be classified into 2. Either they are Portland cement based or they are pure tricalcium silicate based. If they are Portland cement based, the component is obtained by purification of Portland cement, mostly a type 1 general purpose Portland cement. But in some commercial cements like Terracal, they use type 3, which is finer ground for higher early strength. On the other hand, there's pure tricalcium silicate cement, which means that it is synthesized in the laboratory, either by sol gel or sintering technique. They are free from aluminium, which is usually present in Portland cement. And these are the class of cements that are called as bioceramics. So if we have to sort all the cements that are available, commercial ones, we would group a lot of them under Portland cement based and a few of them under aluminium free, pure tricalcium silicate based. And the most famous ones here are biodentine, the endosequence, and the iRoot BP are famous for being premixed. Now, when we talk about the cement component and about aluminium and aluminium free, there have been many studies that analyze the heavy metals in these cements. And these restorations are often shown to leach a substantial amount of heavy metals such as arsenic, lead, cadmium, copper, iron, manganese, nickel, and zinc. but the leaching was well within the ISO limits, and hence these materials were considered safe to be used in dentistry. However, a recent study in 2017 showed that in 3 different cements tested, MTA Angelus, MTA Filapex, and Terracal LC, they used these 3 cements because they have varying amounts of aluminium present in them. All 3 are Portland cement based cements. They found that there is higher level of aluminium in the plasma, liver, and brain samples of the animals treated with these cements. And we know that aluminium is highly abundant toxic metal that is best known for its neurotoxicity and its relation to the pathogenesis of Alzheimer's disease. However, further investigation is required on this matter, but currently all tricalcium silicate cements are deemed safe. Particle size is another factor of the cement component that is very important and plays an important role for the dentist also, not directly but indirectly. We see that some of the cements have a particle size of 30 micrometers, quite big compared to biodentine, which has 10 micrometers, which is quite low. And when the particle size is smaller, it's advantageous because it reduces the setting time and also creates a densely packed material. And if the particle size is larger or smaller, depending on that, you could see here, this is the surface of the material after it's mixed. And you would see the more the red, the more it's rough. So the roughness value is 5.04. And here the roughness value is 2.02. The roughness of a cement is very important because it plays a role in the toxicity of the cement. So to see whether the cells can stick on or cell adhesion to the material, we need to assess the roughness of the material. And the smoother, at least around 2.02, is better than being rough. Now we come on to the second component, and that will be the radiopacifiers. We can sort the radiopacifier, we can sort the commercial cements available based on the radiopacifier used in them. And you would see that the first one, the ProRoot MTA and other MTA variants, are known to contain bismuth oxide, which is not a very good one because we recently know that bismuth oxide is responsible for the discoloration of the tooth. So there were a lot of cements, including MTA variants such as Neo MTA and Metsam MTA, that were launched with other radiopacifiers such as zirconium oxide, calcium tungstate, barium sulfate, barium zirconate, tantalum oxide, etc. In our laboratory, we performed a study to see which radiopacifier would be the best. So we compared bismuth oxide, zirconium oxide, calcium tungstate, barium sulfate, tantalum oxide, strontium fluoride, strontium titanate, and barium titanate, a total of 8 different radiopacifiers. And we kept a pure tricalcium silicate without any radiopacifier as the control group. And we found that radiopacifier does not only affect the radiopacity or the discoloration potential, but the type of radiopacifier used also affects the setting time, compressive strength, solubility, porosity, sorption, fluid uptake, pH, calcium release, bioactivity, and cytotoxicity of the material itself. So we had to evaluate all these 8 different radiopacifiers against these different parameters, and we tried to give them an equal weighted score. And we noticed that any radiopacifier, if added to the tricalcium silicate, it reduces the good properties of the tricalcium silicate. So pure tricalcium silicate is the best, but unfortunately we cannot use it because we need radiopacifier to assess the material that's used later on. So when we go to the next best choice, we found that barium titanate, calcium tungstate, barium sulfate, and zirconium oxide all were the next 4 better choices. So you could see here on the graph with the score that's on top of each of the radiopacifier. And we've concluded in this study that barium titanate and calcium tungstate were the next best choice for radiopacifier. When we move on to additives component, there are many different additives that are added to tricalcium silicates. Here in this study from Sagiri et al., you could see that they compared 9 different commercially available tricalcium silicates, and it could be seen that Based on the number of additives and the percentage of them added, the percentage of the main component, tricalcium silicates, could vary from as high as 94.9, 95% to as low as 30% in gray MTA and gray Angeles MTA. In the two of the pure tricalcium silicate based cements, we see that they are alumina free, and also that they have some other additives such as calcium carbonate and calcium phosphate. So this makes us wonder why these additives are added to tricalcium silicates. So we will take a look at what are the kinds of additives that could be added to the cement component of tricalcium silicate based cement. And here there are a lot of them being researched, and you'll find numerous articles and manuscripts on this. But we will group the best 6, or to say the most studied 6, and those would be calcium carbonate, calcium phosphate, silica and its derivatives, resin, calcium chloride, and glycerol. Now, calcium carbonate, when added to tricalcium silicate, it acts as a nucleation site, allows the formation of reaction rims, enhances the hydration, and produces a denser structure. But what is more important for us is, by means of all these, it creates a shorter setting time. Calcium phosphate, on the other hand, was tested to be added at high percentage, like 50% of calcium phosphate added to 50% of calcium silicates, tricalcium silicates. But then we found that it was found by Wismayer et al. That there was a deterioration of material properties and biocompatibility properties. So it was not a good idea to add such high percentage of calcium phosphate to tricalcium silicate. But on the other hand, in our laboratory, we try to add small quantities of this calcium phosphate. And we found that if it is added in small quantities, such as 5%, it could indeed improve the physico-biological properties of tricalcium silicate-based cements. Next, we move on to silica and its derivatives. Silica by itself, if it is added in quantities of higher than 2.5%, it increases the bioactivity of the cement. But on the other hand, it causes a lack of mechanical strength and an elevated degradability, which is not good for the cement. Mesoporous silica are porous silica with a specific size and the ability to load them with any kind of drugs that we would like, such as antibiotics or antibacterial. And these mesoporous silica, if added at a percentage of 2.5%, improved the biological properties without affecting the mechanical properties. And this could also act as a drug delivery system, which is very positive. Nanosilica are further finer particles of silica, which was found to be, if added in 8 and 10%, accelerated the hydration process and reduced the setting time further. And they had no adverse effect on the compressive and flexural strength. Another derivative of silica is bioactive glass, which consists of silica, calcium, and potassium. And the addition of 10% bioactive glass shows improved physicobiological characteristics. So a few of these additives, such as mesoporous silica, nanosilica, and bioactive glass, have shown to improve specifically the properties of the tricalcium silicate cement in general. Now, another derivative of silica that I would like to talk separately is the anti-washout gel. I would like to talk about it separately because it's not added to the powder component, but it's a liquid component by itself. It's a gel to which the powder component of MTA is mixed. And this is also made up of 97% water with a little bit of silica, potassium, and calcium. And you would see that this caused an increased washout resistance, decreased setting time, increased compressive strength. But the drawback was that it limited the amount of calcium ions released in solution. When resins were added to tricalcium silicates, it sounded like an excellent idea because we would have an on-demand setting material. So the setting time would be decided by the dentist. But the problem when resins were added to tricalcium silicates was they do not exhibit complete cement hydration. The release of high percentage of monomers was seen. There was increased toxicity, and it has been strictly not recommended for use in direct pulp capping. So resin-based tricalcium silicates would need further improvement before they could be used for pulp capping. Another component is calcium chloride, which is also a very well-known accelerator. So the addition of calcium chloride to white MTA and white Portland cement reduce the setting times because it's an accelerator, and also it reduces solubility and increase the pH of the cements in the initial periods. Biodentine uses calcium chloride in the liquid component, and it was seen from studies that this resulted in an increased calcium ion release, not only because of increased calcium hydroxide formation due to the faster setting, but also contributed to the calcium ion release by unreacted calcium chloride. The last additive that we would see is glycerol. Glycerol is added to tricalcium silicate cements because we want the cements to be pre-mixed. A cement mixed with glycerol does not set, does not harden. So it comes in an injectable form. It's easy for handling, it's easy for application. But of course, it requires moisture for setting, but this moisture is usually obtained from the surrounding, like from the dentinal tubules or from the cavity itself. So the drawbacks of this kind of cement was that initially they had decreased radiopacity when glycerol is added, and they showed prolonged setting times, as you could see from the table here, that the setting times were around 7 to 8 hours, which is quite long. And the setting time was also dependent on the available moisture. So if more moisture was present, they set really quick. And if there was less moisture, they took a long time to set. So this was a kind of unknown factor for the dentist. However, we tried to improve, in our laboratory, we tried to improve the premixed cement such that it would have adequate radiopacity by using another radiopacifier and also by adding some additives for faster setting. And we were quite successful to an extent to say that the setting time was reduced to 25 minutes of initial setting time and 75 minutes of final setting time with these pre-mixed cements. And the faster setting time did not also affect the radiopacity. And here from this figure, we could see that if we add the additive and accelerator at 20%, we could see that the cement hardens equally at equal time, around 20 minutes, in both water and in relative humidity, which is like a moist environment where there's not much moisture available. So that would mean that the setting time is independent of the available moisture, which is a good thing. So glycerol needs further studies and maybe could be improved to make a good premix cement. Now, before I finish my part of the webinar, I would like to go through the material properties, and those are the setting time, the compressive strength, the calcium release, the color stability, gene expression, and mineralization potential of tricalcium silicate based cements. Now, if we look at the setting time, I should tell you beforehand that these values were obtained from different studies and hence are not for direct comparison, but just to give an idea of how long each material could take to set. And then we see that bioaggregate has a setting time of 385 minutes. And the next would be MTA with 275 and GC MTA with 233 minutes. But then there was MTA Angelus, which was introduced later on, and it had a setting time of 21 minutes, followed by Biodentine, which has a setting time of 15 minutes, the shortest one. So, and when we go on for compressive strength, we see that bioaggregate has a compressive strength of 22 megapascals. MTA has 57 megapascals. MTA Angelus has 91, and Biodentine has 270, which is very interesting because the compressive strength of dentin is 297 approximately. So to have a cement which would be as strong as the surrounding dentin is an advantage because it could then be used as a restorative material, as is shown in this study that biodentine is able to restore the posterior teeth for up to 6 months as a temporary one. And the problem after 6 months was there was a little bit of anatomical deterioration leading to leakage, micro leakage. So it was shown that up to 6 months biodentine could be used as a temporary restoration. Another study that identified biodentine, ProRoot MTA, and SEM cement, and they wanted to see which cement was the best if you want to layer immediately with composite or other kind of materials on top of your biodentine, on top of your tricalcium silicate based material. And their conclusion was that when immediate layering is necessary, then biodentine may be a better option compared to ProRoot MTA and SEM cement. So this could be, these positive aspects could be attributed again to its higher compressive strength and lower setting time. Also, a recent retrospective study in 2019 showed that when we use a slow setting calcium silicate based material, it will result in higher failure rates than a fast setting calcium silicate based materials. but this was typically checked in patients undergoing endodontic microsurgery. If we move on to the next characteristics of tricalcium silicates, it will be color stability. We know that all the problems started with pro-root MTA showing discoloration, and a color stability is an indicator of how much the color of the material changes over time, and the lower the better it is. So biodentine showed a color stability of 2.78, an endosequence root repair material for 3.45. Bioaggregate had a color stability value of 7.12, while pro-root MTA had the highest, 10.93, which is quite logical considering that it consists of bismuth oxide, which is known to cause discoloration. The next characteristics is calcium release. It's a very complicated graph with too many lines, but I can explain that all the red lines belong to biodentine, the blue lines to Metsam MTA, and the green lines to MTA, pro-root MTA. So this was a study done in our own lab, and the striped lines, this one, indicates the release of calcium ions from a very acidic pH, the solid lines from a neutral pH, and the striped and dotted lines from an alkaline pH. So 3 different environments were chosen to simulate, let's say, an acidic infected tooth, or a perfectly healthy tooth with everything proper as it can be, so a neutral pH, or a teeth that has recently been treated with calcium hydroxide for a very long time, which could have an alkaline effect on the cement. So we see that irrespective of whether the pH was acidic, alkaline, or neutral, biodentine released very high calcium compared to pro-root MTA and Metsam. And this is a positive factor because we know that calcium is responsible for the mineralization potential of the cement. So we also studied the mineralization potential and see that biodentine exhibits faster mineralization potential than pro-root WMTA. Also, there are other studies which have shown that the thickness of hard tissue bridges are significantly higher with biodentine compared to MTA angelus, and also that biodentine and pro-root MTA have thicker hard tissue formation than bioaggregate. So biodentine forms faster and thicker hard tissue bridges, but it's also shown that as far as the morphology of these tissue bridges is considered, there is no difference between biodentine and pro-root MTA. Then we move on to the gene expression, which is the last one. And here we will see 4 different things. That the right gene expression is required for mineralization. And it can be seen that biodentine, iRoot BP+, bioaggregate, and SEM showed significantly higher gene expression than pro-root WMP. And biodentine, bioaggregate, and MTA are known to stimulate the odontogenic capacity of pulp cells by proliferation, angiogenesis, and biomineralization. So this means that if biodentine, bioaggregate, or MTA is brought in contact with pulp cells, which are present in the dental pulp of the tooth, it can stimulate the pulp to turn into an odontoblast. And also, it's not toxic because it helps the cells to proliferate, and it helps the cells to mineralize, and also that it can cause angiogenesis, which means that it helps formation of new blood vessels, which is very important in forming new dentin pulp complex. And this biomineralization we know is done by means of a common pathway that is activated by almost all the tricalcium silicate cements. That's the MAPK pathway. But what is interesting is that biodentine reduced the expression of a gene called TRPA1. So now we have to know, what does this TRPA1 gene do? This TRPA1 is a specific receptor, and it's known to modulate the pain receptors in odontoblasts. So thereby, if biodentine specifically reduces the expression of this kind of a receptor, it means that it may help in post-operative pain relief. And to be honest, biodentine was the only material tested to see if TRPA1 receptor is reduced. So it might be true for other tricalcium silicate cements also, but we are not yet sure. So the take-home message from what is the material properties and what should be my choice of TCS-based materials will be, if the dentist is really if the dentist is really concerned about toxicity or safety, or he treats really young patients, even though there is very little evidence, it would be better to use alumina-free pure TCS-based cements. If you would like a short setting time, then you should choose a cement with specific additives such as calcium carbonate, calcium chloride, etc., and also a one with smaller particle size because it helps in faster setting time. And when there is a faster setting time, it helps you with immediate layering of the material. And if you want to use this tricalcium silicate cement as a temporary restorative material, as is possible with biodentine, then you should look for high strength and minimal leakage. If you do not want discoloration, if you want to use the tricalcium silicate in an aesthetic application, and then radiopacifiers other than bismuth oxide is preferred. If you're going to use the cement in a very difficult area of application, then probably a pre-mixed injectable cement with glycerol would be better. If you are looking for immediate mineralization, then higher calcium release and appropriate gene expression is required. And also, if you suspect that there's going to be some post-operative pain, as per the evidence now, we think that biodentine reduces post-operative pain due to the TRPA1 expression. So, thank you very much. I'd like to give the...
Yes, Dr. Rajasekaran, so we have a few questions from the audience. The first one is the following. Does biodentine release fluoride?
No. Biodentine does not release any fluoride because it's not known to contain fluoride in it. So biodentine does not release any fluoride.
All right. Yes, more direct question. Would you say biodentine basically wins?
Basically wins, yes. With the evidence currently available, and also, as I said, depending on what is your requirement for the tricalcium silicate cement. I mean, if you use it for a general direct pulp capping, I would say yes, biodentine wins because you can use it. It sets really quickly. You can layer it, or you can use it as a temporary restorative material, and it's known to release a lot of calcium and induce faster mineralization. So in that case, yes. But if you want to put it in a very difficult position or application, then probably a premixed cement is better. So depends on actually what is the need of the dentist. So as I told in my last slide, which I cannot show again, I think. Yeah, as I had shown in my last slide here, depending on your need or expectation, you can choose your choice of TCS-based material. But I think that for most of these expectations, biodentine does pretty much satisfy.
Yeah. Another question, does biodentine have any effect on inflammatory mediators or inflammation?
Yes, biodentine releases a lot of calcium, as we have seen, and hydroxyl ions. And we know that calcium hydroxide can stimulate inflammation on the one hand. But on the other hand, biodentine also has some inflammation reducing, such as, by example, the last receptor that I was talking about, the TRPA1, is mediated by TNF-alpha, the tumor necrosis factor alpha, which is also a gene to reduce inflammation. And the study actually was done on inflamed caries teeth to see if biodentine can control the inflammation and reduce the pain. And yes, it reduces inflammation.
Another question, does biodentine dissolve after some time?
Not after its setting time, after its final setting has been reached. So biodentine does not dissolve unless you use industrial grade solvent, which I would not recommend using in the patient's mouth. So I don't think it'll dissolve.
All right. So let me see if we see all the questions. Is there any possibility of injectable biodentine in the future?
Oh, I think that's one for the Septodont company to answer, but I would assume that they're working on it because injectable cements are a real hype, and they would be, of course, very easy for the dentist to use. And I guess Septodont should answer on that. It's probably for you, Sandra.
Yes, but I'm not from R&D, so but indeed, so there are some projects on this. Maybe one last question before we move on. So, because this is our question about indications, and I know we will talk about indications in a few minutes. Yes, this one is, I think, for you. Do you know
Yeah.
Oops. Sorry, I was too quick. Because it's not always easy to see the questions. One moment. Yes. So no, this is an indication again. Will it need any preconditioning before application when it is used as temporary?
No, bioretin does not need any preconditioner when it's used as a temporary restorative material. We know from studies that biodentine has the ability to exchange certain ions between the dentinal tubules and the material itself. And this is a very positive thing because it helps the formation of the resin mineral tags or good adhesion and reduce the micro leakage as such. So no preconditioning is required is the answer to that question.
Yes.
Yeah.
All right. So thanks a lot, Dr. Jessica. So I suggest that we move to the next topic.
Yeah. Okay. Thank you.
So hello, I'm again here, but now to introduce the second speaker, which is Professor Cowles. She's also in our department over 20 years now, 25 years now already. Came in as a master student, but in the meantime, a well-respected colleague professor in the department, head of clinic, and she did a lot in dental traumatology, which is a favorite topic of her. And now she will give a lecture on the use of tricalcium silicates in immature teeth. Just a little minute.
Okay. I'm very happy to be here and being part of the webinar. I'm very happy to share one of my clinical experiences. Yes. Okay, thank you. A little bit of yeah. Okay. So the last decades, significant progress is seen in the field of prevention and treatment of pulpal and periradical diseases, leading to an increasing amount of research. And it's thanks to that research into the role of pulp-dentine complex and its ability to repair pulpa and regeneration of mineralized tissue. Thanks to the better knowledge of pulpal stem cells and new materials that came on the market, and then I'm talking about the bioactive materials, the tricalcium silicate cement, which give us the opportunity to develop corresponding techniques and new guidelines. Now, the goal of all this now is currently is to prevent pulpectomy of contaminated pulp tissue and also to prevent extraction in case of severely infected teeth. Well, we have more than 20 years of experience in use of MTA and now 10 years of experience in using biodentine. And as you can see, I showed here, I listed up the applications which are apexification, capping and pulpotomy in incisors and molars in mature and immature teeth, revitalization, root fractures, root resorption, and pulpotomy in deciduous dentition. Now, of course, it's unfortunately it's not possible to discuss all these applications with you today, but in the scope of this webinar, which is preserving the pulp with tricalcium silicate cement, well, I prefer to talk to you to deal with you the subject of pulpotomy after traumatic injury in incisors, even in mature and in immature teeth. If we consider an immature teeth, we are facing an incomplete root for which further development is depending on the presence of vital tissue, vital pulp, remnants often, on the earthquake epithelial root sheet and the apical papilla in order to see further thickening, lengthening, and closure of the apex. And from research, we know that the epithelial root sheet has regenerative potential also after an acute traumatic injury, whether the damage is due to a direct impact, which can be the luxation, the displacement, or due to an indirect impact, which can be delayed revascularization, for example, due to an incomplete reposition. It has shown that the epithelial root sheet has a very high resistance to long-lasting pulp infections and to partial pulp necrosis. Now, what's important in these cases, well, that mechanical cleaning is not done. It's contraindicated in these cases because not only because if you're dealing with immature teeth, it may weaken the thin dentinal walls. And also, if we want to see an apexogenesis to be happen, we need preservation of vital tissue, which is the apical papilla and the epithelial root sheet, but also, and this is counting also for the mature teeth, that by mechanical cleaning, we may remove vital tissue remnants in the apical part of the canal. And probably we are dealing with a partial pulp necrosis, which is the most difficult thing to discover, of course, in clinical cases. Now, what we have seen and what is also what appeared in the literature is that the presence of an apical radiolucency and the absence of a response to thermal and electrical challenges can no longer be seen as the sole determining factor in evaluating vital tissue or the vitality of tissue. In these situations, well, you still can have remnants of vital pulp and or even apical papilla cells may be still present. So we should take care about these remnants of vital pulp, which we can see in partial pulp necrosis. The easiest treatment we know is the capping, and we know that capping of healthy pulp gives a very high success rate, and the younger the pulp, the better its repair potential. But the most difficult thing is to differentiate an infected pulp to be reversible or irreversible. And I want to show you by a few cases how you can make the difference. One of the first protocol shown for capping is shown here in this figure. So first of all, after an acute, for example, an acute traumatic injury, you have to clean the exposed pulp with saline, and then to cut the infected pulp for 2 millimeters more or less with a high-speed diamond burr under a good water cooling. And then you put minimal 2 millimeters of bioactive cement in immediate contact with healthy pulp. So we remove 2 millimeters of the pulp to be sure that we keep healthy pulp, which is not infected anymore. And you can use, well, we use MTA or biodentine, and the former speaker have explained to you quite well what the difference is between both bioactive cements. To illustrate this protocol, I have a case I want to show you. Here you see a boy with erupting central incisors, dislocation, luxation of the right central incisor, and crown fracture of the left incisor with a pinpoint exposition of the pulp shown on the intraoral picture. So we opened, as you have seen in the protocol, we opened with the diamond burr under a high speed and water cooling. And here you see the exposed pulp. which is not bleeding at all. It stops bleeding spontaneously after just drying with a cotton pellet. And it's very clear to see that this pulp is non-infected. Here we used biodentine and covered the non-infected pulp immediately in immediate contact with this tissue, and we used the biodentine as a temporary filling in the meantime. This picture shows how epixogenesis is going on after 8 months and 10 months, but this treatment can also be done in mature teeth. It's a very nice treatment. Now, more difficult when you have a long-lasting infection, as you can see here in this case, a boy that suffered from a traumatic injury 1.5 years before, and after a few months suffered from an infection. You see on the clinical picture, and the arrows are indicating a gingival edema due to the infection, and the diagnostic X-ray shows clearly an apical periodontitis. So the boy presented in June 2016. So what can we do? Well, of course, it's difficult to know whether we still have pulpal remnants, vital tissue, and whether it's reversible or an irreversible situation. I show you immediately the results of the treatment, and you can see halfway, 1.5 years later after treatment, halfway where the biodentine is placed, and here up on top of the vital tissue. And it's clear that now we have a full formation where we started with a root arrest formation while the other central incisor finished its formation, or it has an apical closure. So we reached this 1.5 years later due to this treatment, and I can show you further follow-up 2018, 2019 with more or less almost an obliteration of the canal, because biodentine or the bioactive cements are triggering the odontoblast, and you have a huge formation of dentine, which gives us a very strong central incisor. Now, how do we proceed to do such a treatment? And I will show you now step by step. First, we start by giving local anesthesia, rubber dam isolation, and access to the pulp. And then we will do a gentle superficial irrigation, which means you don't go further than the pulp chamber with sodium hypochlorite. When you have a huge infection, we'll see that necrotic tissue will come out even if you leave your needle not deeper than the pulp chamber. Afterwards, we take a blunt paper point, which means a paper point from which you cut the tip, and with a flat face, you go into the canal, feeling until you have some resistance. And probably this could be vital tissue. You bend it's easy to know the working length, so you bend your paper point on that depth. This gives us an idea how deep we can go and irrigate again, gentle irrigation again with sodium hypochlorite, but take care that you take 2 millimeter distance from the tissue you found. And probably it's vital tissue, but still we have to find out. If you will irrigate here with sodium hypochlorite on that depth, when you have necrotic tissue, you will see that you will remove the rest of the necrotic tissue when it's still there. And we always follow this sodium hypochlorite rinsage with saline, because also sodium hypochlorite can be necrotic or toxic for vital tissue. And then afterwards, we again dry the canal on that working length with blunt paper points. And depending of the severity of your infection, it is allowed to do a middle step, let's say, by using root canal medication, but also there your medication should keep distance from vital tissue. You can use a mix of antibiotics, and you also can use calcium hydroxide if needed. And then you close, you've finished with a perfect coronal seal. So if you put this medication, you need a second appointment, of course, where you start again as the first appointment with a local anesthesia, rubber dam isolation, access, and again a gentle superficial irrigation with sodium hypochlorite in order to remove the medication, followed by EDTA. Afterwards, we again, in this step, I already take another, again, blunt paper point and I go feeling how deep my working length is and if it's comparable with the one I found in the first appointment. And then again, we will do irrigation with saline and drying your canal again with blunt paper points on the depth you measured before until you feel resistance, the same resistance you felt the first time. And even again with the blunt paper point, and it is possible then if you gave a local anesthesia that your patient will feel something, that it will be sensitive. And often you will find a red dot on the tip of your paper point, which means that you have vital tissue, there is residual vital tissue, vital pulp. It will not bleed because you will not harm the pulp due to the fact that you are using a blunt paper point. So if you are in this situation, then you can be sure that there is vital tissue rest, and then it's time to use your bioactive cement and bring it in immediate contact with the vital tissue you found, and finish always with the perfect coronal seal. When it's not possible to coronal seal with the restoration your crown, it has no use to continue with this treatment. This is important because you can't have ingress of bacteria. And in a third appointment, you can finish by permanent restoration. And afterwards, you don't have to do anything anymore, but just do a follow-up clinically and radiographically. I illustrate again this treatment with a girl of 5 years old who presented a few weeks after a traumatic injury. You can see that at that age, the central incisors are erupting. And she presented with a crown fracture, but no pulp exposure. So we didn't expect it in this situation that we would have a pulp necrosis, but the clinical picture is showing clearly a gingival edema, and the diagnostic X-ray shows apical periodontitis. So in the same way as I showed you step by step, we opened apically after local anesthesia and isolation of the teeth, superficial irrigation in the pulp chamber, and then we used blunt paper points to feel if we could find some resistance at a certain depth, which we did. The girl was quite young, so it cannot take a long time. So you can go very fast, irrigate a little bit deeper than depending of your working length with sodium hypochlorite, but just think that you always take some distance from that depth. So to withdraw 2 millimeters from it. And afterwards you finish by irrigating with saline, you dry with blunt paper points. And then, as you can see in this radiograph, we put calcium hydroxide, but only a little bit in the pulp chamber. No contact with the vital tissue, which we found deeper in the canal. So only superficial away from your vital tissue. This patient came 2 weeks later after the treatment, and we had to convince that we had to reopen again this tooth because everything healed within a few days. No problems anymore, no pain sensation. The edema disappeared due to the fact that calcium hydroxide is an effective antibacterial medium. But of course, we opened again. We can't keep it like that. And again, in the second appointment, the same treatment as I explained with the blunt paper. After rinsing, EDTA, and then saline, we dried again, and we had a paper point, blunt paper point with raw dead, telling us that effectively we had a nice vital tissue left. And then this is a case treated with MTA. We brought MTA in immediate contact with the tissue we found at our at our working length, and followed up the patient further on. No complaints afterwards. You see here how we see a root formation, further root formation 1 year later, and a final X-ray 3.5 years later after treatment, giving us the certainty that that there was still pulp remnants left. So it's important that we preserve even if it's a little bit, but in a partial pulpotomy, if you can follow this treatment, you will see that with your blunt paper points, you really can discover whether you have a healthy tissue left. And due to the fact that you don't, without instrumentation, you don't destroy this tissue, and you don't harm the apical papilla, that our root can form completely, thickening walls, lengthening the root, and a nice apical closure. And also, I can confirm that also the periodontal ligament is perfectly formed around this tooth. Here I want to show you our last case. And for me, it was not a last, but a lost case, because it was really severely infected. And I want to show you, to prove you how strong this epithelial root shield is and how strong apical papilla is. This boy is 6 years old with a crown fracture, no pulp exposure, but presented with an abscess. After trauma, he was referred by his dentist. An incomplete crown fracture, uncomplicated crown fracture. You see that we have only a few millimeters of root formation. There was a huge swelling, and when we touched the tooth, which was hypermobile, pus was coming out from the sulcus. So I think you can imagine how severe this infection was. So local anesthesia again, isolation, access to the pulp chamber, and then we did a gentle irrigation in the pulp chamber. And I can tell you that there was a lot of pus coming out of this canal. We had nothing to lose, of course. So as medication, again, we placed calcium hydroxide for 3 weeks. Patient came back after 3 weeks, again, with the same remark that everything healed within a few days. No hypermobility anymore of the tooth, no pain, no complaints, no edema anymore. So we opened again, gentle irrigation, the whole protocol I presented before. And because of the fact that we still had some, in fact, well, it seemed a little bit rest infective situation in the canal, we decided to put calcium hydroxide for 1 week more after rinsage. We never used mechanical instruments. We never went into this canal with any file, but rinsed thoroughly, blunt papers, drying, and again 1 week more of calcium hydroxide, after which he came back, and then we had a nice dry canal, which is very important if you want to use biodentine, because biodentine will only set in a dry environment. So you need that healthy situation, which is very important, that you should take care and take the time to have that healthy situation. So again, this was one of our first severe cases where we used biodentine. And I can show you after 6 months follow-up, and it's clear that we have a continual root formation. When you compare it with the other central incisor, 80 months follow-up, 42 months follow-up, and 54 months follow-up, and so on. We had also the root is as long as the contralateral as the other central incisor. What is very visible, what we see always is that after a while you don't see the difference anymore between the biodentine and with dentine. So we have a similar radiopacity. And if you don't know that there was a treatment, you would consider this teeth as obliterated. Anyway, it is a healthy situation. Afterwards, the patient had a very successful orthodontic treatment, which means that also the periodontal ligament is left untouched and was perfectly present. So my take-home message is that we should take care now of vital tissue remnants, and that it is important that we go for a good case selection, that we make sure that we disinfect the canal chemically without instrumentation, and in this way we can create a nice adapted environment for the remaining vital tissue. And what is important is and is required to have a successful treatment is that you can coronally seal perfectly to prevent bacterial ingress. Thank you very much for your attention, and I'm waiting for your questions.
Yes, thank you, Professor Coles. Yes, indeed, we had quite many questions. So during the session, I will take a few of them. Some questions came more frequently is about a root canal treatment after complete root maturation following vital pulp therapy. Would you recommend that, or can we leave biodentine forever?
We can leave biodentine forever. Now, if you have a mature teeth and there are still vital remnants, you leave them there. It's exactly the same way of working. So you follow the same protocol. The easy thing is with immature teeth that you you can control your vitality because you can see further root formation. But it is exactly the same protocol to follow in mature teeth.
Yes. Usually IRM used has also temporary restoration, but they don't have a great seal. So do you advise the use of biodentine instead? And if yes, do you add another layer, for example, glass ionomer?
No, I never do, because, well, I have a little trick. My patients, they are not so patient or to wait 12 minutes until biodentine is set. I never put something in between, and it's also already shown in former research that you can cover biodentine immediately by composite. But what I do is I put a layer of bonding, light curing bonding, before covering biodentine by composite. And also, when I use it as a temporary filling, my patient is leaving the chair after I put it a layer of light curing bonding, and after curing, of course, the bonding immediately after placing biodentine. And then you can see after months even the superficial layer didn't change, it didn't dissolve at all.
There was also another question about the concentration of sodium hypochlorite. So for children, what concentration do you recommend?
2.5% is the concentration, and it's not a problem if you're not touching vital tissue. So you take always a little bit of distance when you are irrigating a canal.
Yeah. Also regarding the post-op pain, how do you manage? So this, do you need painkillers? And of course, we are talking about so young patients. How do you deal with that?
When we have patients that had pain before the treatment, I always advise to use a painkiller the first hours after the treatment, which I have seen in partial pulpotomy and a pulpitis, for example, which is not the scope here. But when I treat in 6-year smallers feet with pulpitis, and I discover the same protocol I discover in the pulp chamber or a little bit deeper, still vital, healthy pulp, I leave it there and I cover it immediately in direct contact with biodentine. And I will always advise parents to give a painkiller to their patient. And I have the experience that this doesn't take 24 hours before pain disappears afterwards. But never say, now you will not feel anything anymore. This is, I think, difficult, because I'm very, well, I only want that they take a painkiller immediately afterwards, especially when they present with pain before treatment.
Maybe also a challenging question. So why not place immediately biodentine in the first session? I think in one of your case is calcium hydroxide more antibacterial than biodentine. So
I don't do the step with calcium hydroxide when I don't have pus or edema. But because I have a lot of cases done where I discovered a beginning of necrosis in the coronal part of the pulp, and if there is no edema, if there is no pus found, I immediately, in one session, I cover the vital tissue with biodentine. So it's not necessary, but if you need or if you feel that the inflammation or the infection is quite severe, it's advised to take a second appointment. But if not, I don't think that, yeah, of course I can't compare two patients doing this, but it's depending on the severity of the inflammation. But a lot of my patients are treated without the immediate, the calcium hydroxide step.
Also specific now to the cases you showed, have you encountered root resorption, inflammatory, external or internal, in any of these traumatic injury cases? No. If yes, how would you recommend to deal with that?
I never discovered resorption after the treatment. No. And when I found the resorption, I think before then it is, well, you have to, the first thing to look at it is to try to find out what kind of resorption it is. And if it is an inflammatory resorption, then you go to another treatment, let's say. But I always go looking if I don't find remnants of vital tissue. And if I'm dealing with immature teeth, I always try to keep the apical papilla vital.
Last question regarding a bone fracture, so concomitant to a trauma, does it affect the prognosis of the vital pulp therapy?
Is the question alveolar fracture?
Does concomitant labial bone fracture affect the prognosis of vital therapy?
In case of a lateral luxation, for example, if you have a bone fracture or you have an alveolar fracture, where it's depending of where your fracture line is running. If it's on the top of the apex or the roots are involved, there is a big chance that you will have an infection or a necrosis of the pulp, yes. But if the bone fracture is laying above the apices, then there is a chance that you don't need to do some endodontic treatment. But when the fracture line is running on the level of the apex or through the roots, then necrosis of the pulp is feasible, yes. So then you have to do a very strict follow-up of this case.
Thanks a lot, Professor Cowles, for your replies. So I suggest that we move on with the next.
Yeah, thank you very much.
So now we are going to the end, almost. There's one lecture left, and I will take that for my part. So I will remove first this. And so we go on with the next topic, is a kind of overview, a brief overview of all research we have done, and then at the end, some future perspectives. But before starting the overview, I take you back to May 2010, exactly 10 years ago, when this patient entered the emergency room. I was called up for this little girl with an enamel dentine fracture with pulp exposure, a complicated fracture. And we had in fact the choice to do a direct capping or doing a pulpotomy. But 10 years ago, we decided for the full pulpotomy. And this was my very first patient using biodentine and using it as a capping or a pulpotomy material directly on the pulp, of course, and also use it as an immediate temporary filling for several weeks. So that was a start a little bit for myself in my biodentine career, exactly 10 years ago. Now, here you see some follow-up of the child, where you see all the biodentine and the pulp chamber after 3 months, 6 months, and 12 months. And there you can see some kind of hard tissue formation, not really clear, but indeed something that is looking as a dentinal bridge. And after 24 months, you see also a more fixed bridge, and here you see the apical closure. This is completely in line with Professor Cowles just have told you about preserving pulp in immature teeth, but that's a case of 10 years ago. Parallel to this clinical experience, we also moved into pulpotomies in primary molars. Before over 40 years, we have used in Ghent iodoform paste as a pulpotomy product, which was Tempo-4, by the way, also from the Septodont company, but this is now off the market due to several reasons. In the biological area, we cannot have this anymore, but it was successfully used for over 40 years at our department with a grade with 90% of clinical and radiographical success. But MTA was on the market 10 years ago, 15 years ago. And although the disadvantage of discoloration, we decided in the department in 2009 to leave Tempo 4 for MTA, which was at that time and still is a promising tricalcium silicate cements. But some months later, 6 months later, in May 2010, again 10 years ago, biodentine came on our market, and then we decided to make an immediate change of protocol. You have heard all the advantages already by Dr. Rajasekaran. So we immediately made a change of protocol, and we started also a randomized clinical trial on these pulpotomies in primary molars. We had designed a parallel designed randomized clinical trial where we compared biodentine, the new product, versus the ProRoot MTA, a little bit the golden standard, and versus the older, the former product, Tempo 4 with the iodoform ingredients. We did all therapies according to our guidelines, making the pulpotomy with a 2-3 millimeter layer of the product, in this case biodentine, closing the entrances with plugs, entrances of the root canals. And this was especially the case if we used it as a layer and on top another restorative material. But if we use stainless steel crowns on top, then we filled up the whole cavity with the Tempo 4 product, with the biodentine product. And stainless steel crowns were indeed used in all these cases. First of all, to standardize all treatments, that every pulpotomy had a stainless steel crown for further evaluation. On the other hand, there is literature on that the best survival rate of the pulpotomies is in these teeth, which had got also stainless steel crowns. A follow-up for 6, 12, 18, and 24 months was planned at that time. But we did not succeed the 24 months due to drop-off of children, and to have enough power in this study, we had to finish at 18 months of follow-up. But anyway, no significant difference, nor clinically, nor radiographically, was found between MTA ProRoot, Tempo 4, and biodentine, which in fact shows that the new tricalcium silicate was a very valuable alternative to the former iodoform paste especially, and it equalizes the MTA results, which were known at that time to be very highly successful, between 80 and 90% or over 90%. This was the very first randomized clinical trial published ever on biodentine in pulpotomy for primary molars. But since then, a lot more are now published, and there is even now very recently a systematic review available and meta-analysis on especially primary teeth pulpotomies with MTA and biodentine, but the conclusions are still the same, that they equal and that both are very good to use in this particular clinical applications. Having the RCT running, having other experience, and having some very interesting student at that time, we started up a very first PhD protocol, and you heard the first speaker, which is Siva Prakash Rajasekaran, and here you see in the meantime the cover of his very good book, his PhD thesis, his doctoral thesis on the product. And within this booklet, we have a lot of material property studies. We have also the randomized clinical trial. We have some special casuistic cases, but in other chapters, special attention was given to the calcium hydroxide formation and the influence of pH. For all studies in this PhD protocol, we used the golden standard Portland cement-based MTA ProRoot with bismuth oxide. We used another Portland cement-based MTA, which is MedSem from Swiss, with zirconium oxide, another radiopacifier, and the one comparable to finally biodentine, which is, as we called it, a rather pure tricalcium silicate cement, so not Portland cement-based, with zirconium oxide accelerated by calcium chloride, as explained already in the first lecture. I only will show you two interesting results. I mean, you heard a lot already on the material part, but two interesting results which are also a little bit maybe of clinical relevance. And for example, the calcium hydroxide formation has an enormous meaning for further hard tissue formation and for success of the product. And here we showed in this study, using two different techniques, that calcium hydroxide was formed as well in water medium, in full wet atmosphere, as in relative humidity, which is a little bit the dry medium. And so you'll see that we always have a calcium hydroxide peak in all media here for biodentine with the two techniques, which is XRD and infrared. And for MTA, this is for sure not the case. For MTA, you only have a good calcium hydroxide signal when there is water medium, when there is a wet medium. So this is maybe a little bit of clinical relevance in the sense that it can partly explain the optimal bioactivity in the roots, where we see in studies that hydroxyapatite is formed in dentinal tubules. And within endodontics, where you have no pulp anymore, or on top of the pulp, where you have a dry medium, almost dry, in connection with the dentinal tubules, you see that their biodentines still have the potential to produce calcium hydroxide. The second one, the study is already shown, but the second one is on the exposed surface area, the volume, and the environmental pH on the calcium ion release. It was of most importance to show that there was a maximum calcium ion release in acidic solution. What does that mean? I think that these findings can be of clinical interest in necrotic, for example, immature teeth. Or we came back on that later on in deep carious lesions, where we have an acidic environment per definition. And there we see that the biodentine in this kind of environment can have a maximum calcium, can have a maximum calcium ion release, which is of most interesting to heal and to make sure that new tissue formation will come. We have also seen that biodentine released more calcium than the other products, irrespective pH of the environment. Then I will focus on a very nice drawing by Professor Imad Aboud from Marseille in France, which shows us a little bit what a tricalcium silicate cement do when we put it on pulp. So we have the reaction setting, the setting reaction, of course, of the product, and then what happens or what is delivered to the environment. We see silicium, we see hydroxyl ions, we see calcium. We focused already on the calcium hydroxide a lot, and you'll see what is that doing. We see osteoblastic differentiation, we see an alkaline environment, pH is influenced by hydroxyl ions. We see the pulp cell differentiation and mineralization potential increased. We see also here the mineralization increased by calcium hydroxide, and this all will lead or explain the formation of the dentin bridge formation. Besides the release of all these products, we also have a direct pulp regeneration potential, because the TGF-beta-1 is released also or triggered by the product. And then we see that having this, that pulp stem cells can be recruited and differentiated. And this is again a very important mechanism in the formation of other cells, which are really inducing hard tissue formation. So there's a comprehensive drawing by Professor Aboud, which is of most interest for future research. And then we came on the idea to focus more on the calcium. And here you can see, because the calcium signaling plays a real indispensable role in dentine regeneration, but the responses by the dental pulp cells having the calcium uptake is not very clarified in the literature, is rather unexplored in the literature. And this was really the idea then to set up a second big protocol, a second PhD protocol, which we will have now a little bit explained. And the objective of that study was to correlate the extracellular calcium ion concentration, the intracellular dynamics, the pH, cytotoxicity, and gene expression, as well as the mineralization ability of the pulp stem cells. So the pulp stem cells are stimulated by the product, and then we will study what are they doing with the calcium that they can capture, that they can take up. This was all studied by Doctorandos Ilanagai Ratinam, our second brilliant investigator in our group on these products, and this PhD thesis is ready now. And it was also the goal, the same day of the International Symposium, to have the public defense on May 29th. But unfortunately, we have to cancel this also. But the book is ready. And I will go briefly through three ideas in the book, three results in the book, which again have some clinical relevance. Besides the systematic reviews done, which is a comprehensive study in the book on all gene expression profiling of human dental pulp cells, we will focus now to some three projects more of that book. And the first one is really on the calcium dynamics. Conclusion of this very extensive study was that biodentine released significantly more calcium in the medium where the pulp stem cells are covered, are integrated, than ProRoot white MTA. Both of them had no cytotoxic impact on the cells, and you can see this here. All the green color are in fact vital cells. The viability is here shown. If I had red color, it was in fact a picture of dead cells, but it has happened. It didn't happen. All cells stays, or almost all cells stays alive, as well after biodentine and MTA contact with the pulp stem cells. Now, having known now that we have a lot of calcium available and released by biodentine also, we did some live cell calcium imaging. What does that mean? First of all, this is a patented technique of our Laboratorium of Physiology here at our university, but it shows in fact in live video pictures what happens when calcium is taken up by the cells and how cells react. This is shortly explained in that way. So this is what we could do here. And the first conclusions here were that the larger biodentine-linked calcium release resulted also in altered intracellular dynamics. And that's important that for the first time, I think in literature, the intracellular dynamics of the pulp cells were studied with good results. Further, we could also look at the mineralization of the product as a result of all this signaling and all this reaction of the pulp stem cells. Mineralization was performed, and we could see here after 7, 14, 21 days, respectively for biodentine ProRoot in 2 different stainings in the histology, that we always found a faster mineralization for biodentine, which is shown already here after 14 days. All these nuclei, you can see them here. Already you can see them here. Not the case for MTA. Then after 21, 28 days, faster mineralization of the product. And I think this really supports our clinical findings. It was reported by others, but also it is experienced by Professor Coles, by other clinicians in the group, that we have really a fast mineralization, having dentinal bridges very fast after using the product. And I will show you just 2 pictures here of 2 examples here. One after a partial pulpotomy, where you see here the biodentine on the pulp, and 3 months later you have a full bridge, very nicely horizontal bridge here, full bridge visible already on the pictures. On the bottom here, you'll see 2 micro CT pictures. These are really recent stuff. And we have at the moment a master student working on that in our tooth culture model. And you'll see here two micro-CT pictures, one with MTA, one with biodentine. And after 7 days even on the micro-CT, you see here this beautiful horizontal line, which indeed indicates a dentinal bridge, which again confirms what we clinically see on the X-rays, but really which is also in line now with what we have found in the calcium dynamic studies on the pulp, human dental pulp cells. Another study was the RNA sequencing. It's the most difficult one, in fact, in the whole story, I think. But we have also tried to look after what happens, the signaling, the pathways, the receptors, etc. What's happening really there with the genes necessary for hard tissue formation. And this was also never done before. RNA sequencing after putting products on dental pulp stem cells. This was the very first study in this particular area. And we could express 7,533 differentially genes. And it was very striking that biodentine, the number of expressed genes by biodentine, was much higher than for ProRoot by MTA, as well after 7 days. You see here in this little table that 20 times more genes were expressed by biodentine compared to MTA after 3 days, and also over 12 times more after 7 days. If you look then to the 4 groups, 3 days, 70 days, 2 products, you'll see in the red brownish color the genes that were upregulated, the blue ones downregulated. But here at the bottom, you'll see also a Venn diagram. And if we map the 4 groups together, you can find, or you can see, that there were 180 genes that were common for both products. What is important after all this? Well, it was very important that we could also define 7 signaling pathways related to repair and regeneration, the topic of today a little bit, and the topic of the former speaker clinically. But behind the clinical results, a lot of molecular chemistry is behind, and we could trigger, or we could define 7 pathways all listed on the left of the table. And we could also discover that biodentine triggers all these signaling pathways necessary for repair and regeneration, while for MTA, only 3 of these pathways were triggered. So these findings are also in favor of a faster or better hard tissue formation, let's say biomineralization, for the biodentine product. So the results of this study identified several important processes such as odontoblast differentiation, angiogenesis, neurogenesis, dentinogenesis, and tooth mineralization, with an obvious, more upregulating effect for the biodentine. Of course, a direct extrapolation to clinical experience is never possible, and we have to do a lot of further studies to really discover or refine further all these very difficult signaling processes. Now, a more pleasant study maybe to present, and the last one of these theses is a kind of pilot study on sheep. Yes, indeed, we worked on sheep, which is a very nice model to mimic immature human teeth. And we worked here on sheep for a revitalization therapy. You see here how we try to put a rubber dam even on the sheep teeth. Now, what we did is in several sheep, we used the 2, of course, lower incisors, because there are no upper incisors in sheep, the 2 lower central incisors, and we performed a revitalization completely according to the European Society of Endodontology position statement, which is published in 2016. I will not go into all the details of the protocol, but in a brief overview, we can say that we opened the teeth first in the first session. We inoculated the vital pulp with the own plaque bacteria of the sheep to become a necrotic immature teeth. And after 1 month, we opened the teeth. Well, the teeth were left open. And after 1 month, we cleaned again. We rinsed the teeth roots again, and we put a calcium hydroxide dressing then for 2 weeks. 2 weeks later, we put everything away, we rinsed, and we put all the rinsing materials, sodium hypochlorite, EDTA, and so on in the canals, and we performed the nice apical perforation, and then we have the fresh blood in the canal, put the hematocollagen on top, and on top of the hematocollagen, we put the tricalcium silicate, which was here again pro-root MTA and biodentine. And after 6 months, the tooth became extracted. And I can assure you, we did not sacrifice the sheep further. They are still alive. We have a lot of data, of course, a lot of studies, but I will share with you the histological part. And you'll see here some histological pictures and some micro CT pictures of the extracted teeth. But the most important was that we have found that biodentine induced the formation of a significantly larger area of neoform tissue with cellularity, vascularity, and increased length of odontoblast lining attached to the dentinal walls, and this compared to the pro-root white MTA. Of course, this is a study in a few teeth on a few sheep, and we have to work further to really confirm the data, but these data are very promising and are very in line what we could expect from all the material studies and from all the characteristics so far. This brings me to the last part of the lecture and the last part of the webinar, the future perspectives. And for this, I would like to share with you the idea that we are leaving the more conservative approaches since a long time. We are in minimal invasive dentistry actually, but also we are now again in a period to leave demineralized dentine. And here it is stated not infected, but more recently there is also idea to leave some infected dentine in the cavity and then cover it with tricalcium silicates. This is in fact nothing new. In the 70s, in the 80s, we have already this intermittent excavation, having some infectious dentine left, covered with calcium hydroxide because there was no other bioactive material at that time, and then taking away, waiting for mineralization of the dentine, etc. But this story is left already end of the 80s, but now it's coming back with the new potential of these tricalcium silicate cements. Here you see also a statement already by Dye in 2011 that of course we knew that the products has an ability to induce mineralization in demineralized dentine. And ATME in 2012 published this now study about the mineral infiltration zone, where you can see that in the tubules we have really biodentine, but also further in the tubules hydroxyapatite is produced or is induced. So we see remineralization possibility of acid-affected tissues. When biodentine came on the market, we received a very nice R&D, research and development file from the company with these two very beautiful pictures with the hydroxyapatite crystals within the tubules. Of course, this is from their own R&D department, but in the meantime, we have found, or we have seen, a beautiful publication by ATME again in the Journal of Microscopy. And in one view here on the top of all the pictures, you'll see all the white areas, and all the white areas are just new hydroxyapatite formed by the biodentine product. It was compared to a glass ionomer cement, and you see that nothing happened in the tubules at all. With the glass ionomer cement, in contact with the glass polymer cement. So biodentin shows here really its bioactivity inducing no appetites, and this supports the study to use it also more in demineralized dentine. Now I show you a case of a 10-year-old boy with two very deep caries 6-year molars, the 4-6 and the 3-6, and here the accompanying X-rays, where you see on the one hand an almost contact with the pulp horn, and on the other hand, the right hand, you see here a complete contact with the pulp by this deep caries lesion. Yes, there they are again. And now we go into therapy. For the 3-6, we decided to do a full pulpotomy. And so the pulp was taken, the whole caries, the cavity was cleaned up, the pulp chamber was cleaned, and you see here the full pulpotomy with biodentin, and afterwards then covered with a composite restoration, as you can clearly see here on the bottom left. That was the one therapy. The other therapy was here on the 4-6, where we have, after thorough excavation of the caries, we didn't have contact with the pulp, but it's very close. So we could do, in fact, an indirect capping with biodentin, clearly shown here, and also on top of the whole, in the whole cavity, a composite, nice composite restoration was made. Here you'll see again the X-ray, and then after treatment with biodentin here in this cavity. Now follow up on top the 3-6 with the full pulpotomy, baseline treatment, and here the final result. And you'll see here after 1.5 years, you can see really two horizontal, beautiful lines, which really show you again the dentinal bridges formed here in the canals. At the bottom, you'll see the partial pulpotomy, or not pulpotomy, sorry, the indirect capping here with the biodentin in place. And if you look very carefully to the pulp chamber on this X-ray and the pulp chamber on this X-ray, you'll see that in this area of the pulp horn, where was the coverage with pulp with biodentin, you'll see a huge cloud, a grayish cloud, which show again the formation of hard tissue in that area. On top of this, you see also in both cases the closure of the apical area. Another one is this, a very nice one to show here, a pulp which is laughing to you. I always use that in my lectures, that here after excavation, all of a sudden the pulp is closed. It's not opened yet, but very close, and there are some remnants now on infectious dentine. In time, this was for sure endodontics. When we studied, it was a 3-canal endo. Now we say stop, stay away from the pulp. We will preserve the pulp system. And so here you see also in that area where the pulp was almost exposed, a full coverage here in the bottom, a full coverage with biodentin. And then in the follow-up baseline and 1.5 years later, you see here again that the pulp chamber, if you look carefully to the photos, which are almost equally with the rinse made, that you see that the pulp chamber is smaller now. And if you look very carefully, we try to find out the border from biodentin and the pulp system, you see a bigger area formed here present under the biodentin coverage, which is really expressing again hard tissue formation in the pulp chamber. And also here, there is a difference in closure of the apex. And this all shows that the teeth stays vital. So deep carious lesion is something that we would like to add now in this very beautiful graph of Professor Abboud. And I think we can also now reversible pulpitis, because this is very clear that deep carious lesions is almost a pulpitis, not really, almost, but even with symptoms of cold and heat, but no knocking pain, of course, with cold and heat, you can still do a direct capping or indirect capping more and deep carious lesions with the tricalcium silicate. And what will happen then? We will trigger all the same things as discussed before. In deep carious lesion, we will have a degradation of the collagen, and this will also trigger the TGF-beta1 factor, which is of course important to trigger the pulp stem cells, and then we can have probably biomineralization also in deep carious lesion. But this has to be studied further, of course. So I think a huge future is there, not only when pulp is exposed or not in immature teeth which are traumatized, but nowadays in all deep carious lesions where we are close to the pulp tissue. My lecture is also coming to an end. So what is the future of these products and also the future of our research products? Well, on the one hand, still improving the tricalcium silicates, especially the biodentine product, because we are on this in this kind of research in the pure, because we are really synthesizing our own tricalcium silicate. So I mean here the non-Portland cement-based cements. And you had a lot heard already of using other radiopacifiers, using bioactive glasses, calcium phosphate, nanoparticles. We can all additives for the currently existing powder or the purely synthesized powder as we have in the laboratory, to try to improve everything of what we have now already. The mesoporous silica was introduced in the first lecture. Well, this mesoporous silica, if we can have a product with this silica, which is not having a minor physical characteristics of the product, then we can load that silica with some agentia, which can be antibacterials or antiseptics, for example, chlorhexidine or antibiotics. And then we load the product, and in certain environment or in acidic environment or when in low pH, then it can be released and do, let's say, a disinfection of carious dentine. And then we hope that the disinfected dentine will also recrystallize or remineralize. And then finally, the glycerol is also indicated to make a premix cement. And I think everybody would welcome a premix biodentine, because anyway, the handling properties are something that you have to learn. Finally, we have a second big idea or a big project going into deep carious lesions. In our laboratory now, we are able to isolate our own human dental pulp cells. We have also experimental or functioning a tooth culture model to study all pulp reactions on products. And now we are busy, or we are really exploring to develop a human carious tooth model. And the whole deep carious lesion idea has already led to a third PhD protocol approved by our Faculty of Medicine. And now we are really already progressing. We made progress already a lot to make this model, but of course it's too premature to present this today. But if we succeed here further, we can study regeneration of carious dentine, biomineralization of carious dentine, disinfection of carious dentine with this model. And both models on pulp, on carious teeth, lead all to the study of the finally induced dentinal bridges. In conclusion of the whole webinar, I think tricalcium silicates are really the future to preserve pulp. Biodentine as a pure TCS showed superior characteristics and also a clinical success in a huge number of indications. Now, from our own studies, we know that there are different calcium kinetics and gene regulations, and these are the key factors why biodentine is superior in the formation of hard tissue. And further improvements are always needed, but also here to study future regeneration of carious dentine and biomineralization. All these studies were not possible if we didn't have a lot of collaboration and support. I will not summarize them. Well, they are summarized here, but I will not date them all. but a lot of departments of our own faculty and abroad have worked together with us, or we worked together with him. We were everywhere, we were welcome to do the studies. We were supported indeed for the real experimental and expensive studies. We were supported by the Septodont company, but as said before, they had no input in the design methodology and even the data or publications that we have done and that we will do in the near future. Besides all the laboratories, of course, I would like also to thank all the collaborators, especially investigators, the 2 PhD students, Dr. Rajasekaram, Dr. Ratinam, which are really devoted in the laboratory to do all this research. Finally, I would like to thank the speakers of today, and I think this can be the last slide, to thank them for the nice contributions to this webinar, and I thank all of you in the cloud for your kind attention. Bye-bye.
So thank you, Professor Martens. So I think we have got today a very comprehensive overview of so the tricalcium, tricalcium silicates. So from a material point of view, this landmark also PhD on the biological so activities. So that's beautiful, and some very nice cases in the future. I've got some questions, obviously. One is the following: in deep various lesions, can the biodentine be placed as a base and a permanent filling? And in case of composites, which have some leakage, does this interfere with the biodentine?
Well, the first question is, the answer is that indeed you can do it as a direct base cement. First, no problem. Secondly, you can also use it as a full material, illustrative material, but that's temporary. So far, we only have studies until 6 months in the mouth without any problem. We know, and I think Professor Coles can confirm this, that we have a few cases 2 and more years, even 3 years in the mouth, where the product is beautiful in place. We are doing studies abroad, Belgium, in Nepal, with really in a remote village where children have no access to dentistry, and where we have put in very deep carious lesions biodentine, and we know also after 1 year they are still there. So you can have this a long time in the mouth as a permanent filling. But of course, this is not meant for that. Biodentine was initially meant for mimicking human dentine and not as a restorative. But the properties apparently are good to have them for a long time in the mouth. That's the first part of your question. The second part about leakage. There are studies, we did not show them today, but there are studies comparing glass ionomers cement in double sandwich, in open sandwich techniques with glass ionomers cement, having biodentine open in the mouth, and there is no difference at all between micro leakage between, it was from 3M company, the 3M glass ionomers cement. I don't know the name. No, I don't need. No. Anyway, from 3M company, the glass ionomers cement, and then we have also the biodentine, and no leakage difference at all. So there are indications to use it for a long time. But on the other hand, we have also, you have also seen in my cases, we put composite on it. And as Rita has explained, there is no problem. Damaschke from Germany showed that you can do after 3 minutes already, really etching the walls and do bonding and composite without any problem. And shear bond strengths are the same if you wait for 3 minutes or you wait for 15 minutes. So this was also a nice study that proves that you can do really composite on top. I hope this is a complete answer.
Yes, very clear. Also, to come back on so the deep caries, how much caries do you leave in the cavity? And would you recommend to rinse, disinfect before using biodentine?
Okay, this is a little bit tricky. There is no guideline to give you a number of microns or 1 millimeter or whatever to leave carriers dentin. I think you should be, it is a clinical feeling for the moment. I think we should go into studies, and if we could succeed our model, then we can study how many carriers you can leave, but this is not known by nobody now. But what we do is, of course, excavating the carriers. And then if you expect then a pulp, then you can just excavate further circumferentially in the cavity, staying away from the chamber, from the bottom of the cavity. So not from the chamber too, but from the bottom of the cavity, you stay away and you really remove all the carriers under the cusp, etc. So you can leave for sure 1/10, 2/10 of millimeters at least of carriers, and then put it immediately on top.
Very clear. Last question regarding MIH, so molar incisors hypomineralization. Can you use biodentin in some molars with such molars with deep caries lesion?
Yeah, it is really an indication in our clinic. So in MIH molars, because of two reasons, in MIH you have more sensitivity when you talk about deep caries. So Siva explained that there is really, and there is also a publication by Abud, who shows or who explains that sensitivity is less or is going down with biodentin in a deep lesion. So that's okay. And yeah, I think that's most important, because to give comfort to patients. So one of our guidelines is in severe MIH molars to really excavate them the best you can, then put a coverage, put biodentin, and then cover with a stainless steel crown.
Yes.
This especially in case if we don't want to keep the 6 years molar in time. Yeah. If there is cusp breakdown, I mean, this question is very interesting, but you have to see the clinical picture. If there is no cusp breakdown and there is deep caries, you still can keep, of course, biodentin and the composite. But if there is cusp breakdown too, which we see a lot, then we cover it also with the stainless steel crown.
Just to be clear, do you recommend to disinfect the cavity? Or...
yeah. The second part of your the second part of your question, no, we don't advertise that. No.
All right. So I think we have reached the time we set for this webinar. So again, thanks a lot, Professor Martens and the entire team from University of Ghent. So yes, we can see all of you now.
Yeah, they are still here. They are still here.
Yes, thanks a lot, Professor Carlos and Dr. Aja Sikaran. So I think we have got a lot more of questions, but I think we have addressed most of them, and also a long list of thank you again. So so it was an honor to have you all three today with us. And to our participants, I hope they have enjoyed this as well. So it's time to leave you here and wish you all the best. Take care and bye-bye.
Bye-bye from our side too. It was a real pleasure. Bye-bye.